My hope is that the attendees at this meeting will walk away with a better understanding of which topical medications are most likely to work and least likely to irritate the skin of their patients. Our older products were much less efficacious and also tended to cause much more in the way of intolerability. And our newer products, highly efficacious, work fast and work well with very low tolerability issues. Our old favorite standby, the modified release doxycycline, also highly effective with very few side effects. So just remember that our toolbox is quite full. I'm very happy with the drugs that we have for papulopustular rosacea, and just make sure that you're using them in combination if a solo agent doesn't work well enough. For vascular disease, we have our alpha agonists to help to suppress the background erythema. For flushing, perhaps a beta blocker like carvedilol. We also have botulinum toxin now for treating the flushing of rosacea. So we're in pretty good position. So unmet needs in rosacea, I think, are primarily around flushing. We have the alpha agonists that do a nice job with fixed facial erythema, but we're not quite there yet with flushing. We have two things that people use quite frequently: the beta blockers, with carvedilol appearing to be the most effective with the fewest side effects, and botulinum toxin, which unfortunately is expensive and generally uncovered for this indication. So that's the area in which I'd like to see some work being done. Perhaps that flushing could also help a menopausal flush as well. So kill two birds with one application. As far as acne is concerned, I'm happy there too with my toolbox. You know, in the last 10 or 15 years, we've come a long way in topical treatment for acne and rosacea. And in acne, I guess my wish list would include something that works as beautifully as isotretinoin with fewer side effects. But that's sort of a pie-in-the-sky crazy wish. Isotretinoin is more than 40 years old now and is still the gold standard in acne therapy. So perhaps some of the newer lasers will be able to give us the improvement and the durability of response that we see from isotretinoin, but I don't think we're quite there yet. I'm not aware of any drugs in the pipeline for acne or for rosacea, especially topically. That doesn't necessarily mean there aren't any. That just means the news has not come to me yet. I think our biggest possibility is a biologic agent, which turns out to be good for either one of the diseases. And we also, in phase 1 studies, we have an acne vaccine, which may or may not come to fruition, but we're talking way, way far away at this point.